Started. Good morning all. So I'll be talking on subjective refraction. So the aims of subjective refraction, it is meant to get the ideal spectacle power, and it's carried out after objective refraction or even without that. It's done usually 3 to 4 days after hometropy or cyclopentylate refraction and 14 days after the use of entropy. So the steps are monocular subjective refraction, then binocular balancing and correction of near vision. Starting point is based on the retinoscopy values, auto-ref readings and present glass readings. So you can get the best vision sphere and cylinder through trial and error method. Then selection and verification of the baseline starting point. Then you do the refining and refining the power and axis of the cylinder. Then refine the power and finalization of the sphere. So after objective refraction, make the correction for your working distance. Either add minus 1.5 ds for 2/3 of meter or remove the working distance lens if one was used. So this depends on the patient's response, and determination of astigmatic portion is more complex when compared to the spherical one. So we have all this in your armamentarium, that is astigmatic dial, Jackson's cross cylinder, astigmatic block and fan and stenopic slit. Keratometry, corneal topography, abrometry and AR readings also help you to determine the amount and orientation of astigmatism. You should have an idea of the Strum's conoid. So here the vertical meridian will be giving you a horizontal line, and the horizontal one will be giving you a vertical line, and in between you will be having the circle of least confusion. So how to use an astigmatic dial? Suppose this patient is having a compound hypermetropic astigmatism. So this patient will try to try to accommodate and get one meridian focused on it, on the retina. So in order to, with the help of accommodation, in order to avoid that, you have to put a fogging lens. This will reduce the visual acuity to 6/18 or 6/24, and the astigmatism will be made to a compound myopic astigmatism. So then you ask the patient to look at the astigmatic dial, and they'll be seeing that horizontal line which is closer to the retina as a clearer one. So then you have to push the anterior focal plane backwards onto the retina by putting a minus cylinder at 90 degree. Once all the axis, all the lines in the astigmatic dial become clear, that is the end point of the cylindrical power correction. Now you have to remove the plus sphere. Slowly you have to reduce the fogging lens in minus 0.25 steps and find the best corrected visual acuity. You can use a Jackson's cross cylinder also. So this is a combination of two cylinders kept at 90 degree, or you can consider it as a spherocylindrical combination where the power of the sphere is half that of the cylinder. So this gives you a greater accuracy. You can discover if a cylinder is present or not. You can refine the axis. You can refine the cylinder power. So this patient is having a spherical error, and you can put the JCC in such a way that in one axis is at 90, the other at 180, then flip and see which whether there is any choice for the position. So if all the positions are same, then there is no cylinder. If the patient prefers one position, there is definitely an astigmatism. So how will you refine the axis of astigmatism? So this patient is having the trial cylinder kept minus 1.5 at 180. You can keep the axis of the handle of the Jackson's claw cylinder parallel to the axis of the test cylinder. You can see the red line, that is the -1, and the black line in the JCC, that is the +1. So slowly give two flip choices and ask them which one is clear. Suppose the patient is saying that the first position is clear, then you have to slowly rotate it towards the test cylinder being a -1, you have to rotate it towards the minus, that is the red line on the JCC. If the other position is clear, you have to rotate it to on the second one, you have to rotate it towards the minus cylinder. So minus cylinder should be rotated towards the minus only. If it's a plus cylinder, you have to rotate it towards the black one. Then again give the choice. So this patient, once you refine it is 160 degree, you can again give flip choices once more and see which one is better. If it is a high cylinder, you can rotate only 2 to 3 degrees, like -3 or -4 cylinders. If it is minus 0.25 or 0.5 cylinder, you can rotate it up to 10 degrees. So how will you refine the power? So this JCC is kept in such a way that the axis of the JCC, one of the axis will be parallel to the axis of the test cylinder. Then you give the flip choice. See if one is better, then you have to add or reduce the power according to the power of the JCC, which is parallel to the test cylinder. The one point to remember that the spherical equivalent will be equal in all positions. Whenever you change the cylinder, you have to change the spherical equivalent also. The end point of JCC is when all the flip choices are equally clear. For smaller power JCC, you can use a smaller JCC cylinder of 0.25, higher power is 0.5 or -1. The other one is the astigmatic fan and block. Then you can use a stenopic slit, which is a simpler instrument. It requires only a visual acuity chart, trial frame and trial lenses. It can detect higher amounts of astigmatism and irregular astigmatism that can occurs in cases of keratoconus corneal scarring, post-surgical irregularities or severe dry eye. So the slit aperture acts as an elongated pinhole, allowing light in one axis to enter the eye. The other principal axis causes a blur in the Strum's conoid, and that will be avoided when you use a slit. The size is, it's 1 mm wide and 15 to 25 mm long usually. So this patient is having a -2 spherical. Now you can slowly keep the slit and rotate and find the principal meridian. So the patient will be seeing clearly in one axis, that will be the principal meridian. And you can slowly increase or decrease the power of the spherical lens and find out the best visual acuity in that meridian. Then you can turn it at 180 degree and then again find the spherical power. So difference between these two meridians will be the power of the cylinder, and the axis should be given in the principal meridian. Then next is the refining the sphere. You can slowly remove the fogging lens by slowly reducing in steps. The end point is when both meridians are equally clear. Now you have to refine the spherical power. So once the cylinder is corrected only, you have to refine the spherical power. So this is based on the duochrome test. So it says that the red line will be focused behind the retina, and the green will be focused in front of the retina, and in between the yellow will be focused. That should be the ideal point. So in the second picture, you can see that the green is, the red is behind and green is in front. You have to ask the patient to look at the color charts and ask them which one you can see it is black and boldest. So that will be the and it should be, and if the red is clear, I mean if the letters in the red is clear, that means it is a little undercorrected, and you have to give a negative power to move the red backwards. And if it's a green that is clearer, then you have to put a convex lens. So the mnemonic is, if it is a RAM, that means red. For red you have to add minus, for green you have to add plus, that is gap. Then more about duochrome. Can we do this in color blind? Yes, you can do it in color blind, because the test is based on chromatic aberration and not color vision. And if accommodation is overactive and the patient may accept more minus, you do it under cycloplegia. And it can be used only if the visual acuity is 6/9 or better, as they need to distinguish between 0.5 differences. And the last one in your trial set is the pinhole. It's 1.2 millimeters size, and it can be from 0.9 to 1.75 millimeter. It's also effective. The principle is that light passing through the principal meridian will go undeviated. Sorry, principal axis of the lens will go undeviated, and there will be no blur circles. And the light will fall on the fovea. In order to make it fall on the fovea, you have to correct the IPD once you put the pinhole. And it can detect non-refractive pathologies also. So outcomes of pinhole is, if it improves to best corrected visual acuity, it means there is a refractive error. If it does not improve, it means there is an ocular or a neurological issue. And if it is worse, that means there is a macular pathology. If it's better than BCVA, there is irregular astigmatism. So the cardinal principles in doing subjective refraction, it's both an art and a science, and patients do not always respond accurately during testing with JCC or during duochrome test. So starting with an objective assessment of the patient's refractive error will help you to stay on target with your refraction. Keep it simple, avoid needless detail or jargon, maintain your patience to avoid frustration, grow slowly when needed, and try to make choices as easy as possible. Provide encouragement, especially when you refract a hard patient who is hard to refract. Proceed with a purpose. Do not offer more choices than are necessary to establish your endpoint. Boredom and fatigue can result in poor subjective responses. Thank you for your personal patience.
Thank you, Dr. Rani, for enlightening us on subjective refraction. Now you have found monoclely what more to be done? To speak on this, I call upon Dr. Anita Balachandran from Regional Institute of Ophthalmology, Trivandrum. What more to be done after monoclely seeing in a patient?